All right, we'll get started. I want to make sure Usman has plenty of time to present today. So welcome everyone to Cardiology Grand Rounds. It's our pleasure to welcome our fellowship candidates who are interviewing today. We're very excited to have Dr. Usman Tahir present on hypertrophic cardiomyopathy. Dr. Tahir is a graduate of our cardiology fellowship and a KO8 awardee. He currently serves as the director for the Center for Cardiovascular Genetics, as well as the co-director of the Hypertrophic Cardiomyopathy Clinic. And he's going to tell us more about the old and the new associated with HCM. Thank you very much, Usman, for presenting today.
Thanks, Artie. I really appreciate getting the chance to present here today, and a warm welcome to our candidates. It wasn't too long before, where I was sitting actually in your shoes. And while there was excitement to be at BI at that time, I would say that the excitement now is on steroids. And so I hope that you get that sense as you spend some time with us today. So hypertrophic cardiomyopathy, out with the old, in with the new. I just want to clarify, this does not have anything to do with Albuxtin. This is purely about hypertrophic cardiomyopathy. Al, I just want to clarify that before we start, okay?
Thank you, Usman.
Okay, so when we first started our hypertrophic cardiomyopathy clinic about 1.5 years ago, it was really an incredibly exciting time. We were in the middle of a lot of advancements in HCM. And HCM really has been on the front lines of precision medicine. And the term precision medicine really gets thrown out quite often. And really, anytime you have advancements in an understanding of a field, you're moving towards precision medicine. But I would say for HCM is really all the years of trying to understand this disease process, really over the past couple of years, has come to fruition in terms of therapeutics, but prognostic modalities, and just the management of our patients. And so it's been an incredibly exciting time. And what I hope to impart on you today are 3 really important points. One is really understanding the current genetic paradigm for hypertrophic cardiomyopathy. Second, we'll review new risk markers for sudden cardiac death and hypertrophic cardiomyopathy. And then finally, review the role of novel myosin inhibitors in the management of HCM. And so we'll start out with genetics, and the traditional view has been that HCM is an autosomal dominant condition. So you have 50% risk of passing the mutation from one generation to the next. And while we've known this for quite a number of years, even from the beginning, when Eugene Braunwald first described case series of hypertrophic cardiomyopathy, that this actually travels in families. This thickening of the heart of unexplained nature is a familial disease. And this was known back then, but it wasn't really until the early 90s, actually 1990, when the Seidman group first identified the gene that was responsible, one of the genes that was responsible for the development of hypertrophic cardiomyopathy in patients. This was the first description of the myosin heavy chain being implicated in hypertrophic cardiomyopathy, and subsequently the MYBPC3 gene was also one of the main genetic factors for hypertrophic cardiomyopathy. And we've known now over the past several decades that there are other genes within the sarcomere, within the contractile unit of the myocyte, that are implicated in genetic hypertrophic cardiomyopathy. And these make up about 40 to 50% of hypertrophic cardiomyopathy patients. Well, the real question is, okay, fine, this is 40 to 50% of patients. What about the rest? Are they not genetic? Are they different types of hypertrophic cardiomyopathy? It wasn't until really recently where we have really tried to get a good sense of who are these sarcomere and non-sarcomere hypertrophic cardiomyopathy, and really they are distinct subgroups. This is an analysis using about 2,800 patients with hypertrophic cardiomyopathy who have had MRIs, and dividing them up into individuals who have sarcomere mutations and those individuals who don't have sarcomere mutation, so non-sarcomeric mutation, HCM. And what investigators, including Warren Manning, who's one of the premier imagers in our division, found was that individuals who have mutations in sarcomere are more likely to have late gadolinium enhancement, so more fibrosis, and less likely to have LVOT obstruction, while individuals who are sarcomeric negative have more of that isolated basal septal hypertrophy and less late gadolinium enhancement, but more LVOT obstruction. So these really do seem like they're two distinct subgroups. And within this analysis, they've also found that the individual with sarcomeric mutation negative, who are sarcomeric negative, also have more comorbidities as compared to individuals who have cardiovascular comorbidities, including hypertension and diabetes and elevated BMI, as opposed to individuals who are sarcomeric positive. So again, just getting to the fact that these two subgroups are somewhat different. And when you look at long-term outcomes for individuals, the burden of disease, the cardiovascular disease in sarcomeric HCM, individuals who have genetic hypertrophic cardiomyopathy or monogenic hypertrophic cardiomyopathy in a sarcomeric gene have more events, composite events, ventricular arrhythmias, heart failure, and AFib. And so this kind of gets to the point that while sarcomeric positive HCM and sarcomeric negative HCM are in fact HCM, they're the same, but they're actually different. And so while sarcomeric HCM, the causative genes are often known, rare variants with some modifiers from common variants. In sarcomeric negative HCM, really you have a whole host of factors that may lead to the phenotype, including polygenic inheritance and other comorbidities that may be at play. And this is quite important because as you talk to your patients about what their risk is for passing on hypertrophic cardiomyopathy in the family, knowing the genetics really does help out. And I want to make it clear, we don't use the gene mutation as a risk marker for an ICD eval, but I do think there's important implications for knowing whether your individuals are sarcomeric positive or sarcomeric negative. And just a comment really on the role of comorbidities in sarcomeric negative HCM. Individuals who have a higher genetic predisposition to a host of cardiovascular factors here on the left, on the y-axis, specifically diastolic blood pressure and systolic blood pressure, end up having a greater chance of developing sarcomeric negative HCM. And blood pressure is obviously an important factor in a whole host of cardiovascular conditions, but especially for sarcomeric negative HCM, where genetic predisposition to elevated diastolic blood pressure really increases your chances here for developing sarcomeric negative HCM. So I think we've moved now to thinking about, in terms of genetics, hypertrophic cardiomyopathy as a heterogeneous population with distinct subgroups and different inheritance patterns, really influenced both by genotype and potentially modifiable risk factors. And this is oftentimes very difficult for patients to understand and comprehend. And we're very lucky in our multidisciplinary HCM clinic to have Caitlin Finn, a genetic counselor, who has provided an incredible value to our patients to explain some of these concepts of inheritance and how this may affect family members in the future. So we'll move on to now sudden cardiac death risk markers. So we all know that individuals with hypertrophic cardiomyopathy do have an elevated risk of having a sudden cardiac death. And traditionally, one of the metrics we've used is a drop in systolic blood pressure during exercise as a risk marker for primary prevention ICD and hypertrophic cardiomyopathy. And in fact, in the 2011 guidelines, AHA and ACC guidelines, risk factors for sudden cardiac death included in there are a family history of sudden cardiac death, LV wall thickness more than 30 and unexplained syncope, but also NSVT and abnormal BP response. Now you can imagine that a drop in blood pressure, while maybe indicating some risk, is very nonspecific. It can be for a host of different reasons, whether it's due to some autonomic issue, whether it's from the LVOT obstruction, and often these individuals have a lot of other risk factors that may be obscuring the picture. And so over the past several years, there's been more of a focus on identifying higher risk substrates that are specific to markers of sudden cardiac death risk. And one of these new markers has been the development of left ventricular aneurysms as a new risk marker for sudden cardiac death. And this is data from Rowan and Marty Marin's group looking at LV aneurysms and the fact that they generally have a higher risk for not only sudden cardiac death, but also other adverse events, including thromboembolism and heart failure. Now, in this analysis, there was no difference in terms of whether the size of the aneurysm has anything to do with sudden cardiac death risk. And so what small aneurysms, big aneurysms, it was all the same, relatively speaking. Obviously, this is a small cohort, so power is an issue here. But more recently, there's been evidence that, well, maybe aneurysm does matter. And individuals who have small aneurysms may not be at much of a higher risk as compared to individuals who have larger aneurysms, where, as you can see, the sudden cardiac death risk here is significantly elevated. And so this, I think, is an important concept here, where currently speaking, in terms of we'll talk a little bit about the updated guidelines, where aneurysm, having a left ventricular aneurysm is a new risk marker. The aneurysm, the guidelines don't really differentiate size of aneurysm, but this may change in the future as more and more cohorts are published and we get more sense of the data. A second risk marker that has been really important in terms of our clinical practice is the identification of late gadolinium enhancement. Now, we know that hypertrophic cardiomyopathy, one of the hallmarks of HCM, is the development of fibrosis. And this is well known since the 60s, looking at autopsies. And late gadolinium enhancement is a way we can identify or correlate the amount of fibrosis that may be within an individual. And this actually is a nidus for the development of sudden cardiac death. And we see here that individuals who have a large amount of LGE, more than 15 to 20%, really do have an elevated risk for development of sudden cardiac death. And this actually is independent of other risk markers. And so really an important finding that has been validated in other cohorts as well. And so this has really led the ACC and HA to re-up their guidelines. And just recently, 2020, the guidelines have changed now, and you'll see that the systolic blood pressure drop that we initially commented on is no longer part of the main criteria for identifying individuals at high risk for sudden cardiac death. What has replaced that are three things. One is a drop in EF of less than 50%. I think that's pretty intuitive. When you have hypertrophic cardiomyopathy and now you've dropped your EF, that indicates the high-risk substrate, individuals who may be going on to develop heart failure or burnout HCM. What's included now is the apical aneurysm. And again, size here is not quantified. This may change in the future, but at this point, any apical aneurysm is considered a risk factor. And then you'll see lower down is the use of extensive LGE on CM1. This is greater than 15%. Which is given a class 2B. So what I think is going on here, and I think it really represents that we're moving now towards identifying risk markers that are very specific to high risk substrates in HCM as part of the guidelines for primary prevention ICD selection. So I think this, again, moving towards more of that precise substrate that we think may be putting individuals at risk. And as part of our multidisciplinary clinic, we're really fortunate to have both Dr. Peter Zimmerbaum and Dr. Daniel Kramer, who really help us in identifying individuals who may be at elevated risk and who may need an ICD. Now, again, in our clinic, we employ shared decision-making process because none of these decisions are black and white. There may be some black and white situations, but a lot of these are on the borderline cases, and really getting a sense of how patients feel about their risk, about their long-term, about their long-term risk is really important. And I think we really do apply that in our clinic. And so finally, in terms of updates in hypertrophic cardiomyopathy, one of the most common medications we've used in the past to deal with hypertrophic cardiomyopathy, and specifically obstructive hypertrophic cardiomyopathy, are beta blockers and calcium channel blockers. And so while these medications do help with symptom control in hypertrophic cardiomyopathy, there really has not been a specific medication designed to treat hypertrophic cardiomyopathy, getting at the mechanism at play. And so, going back to basic science here and really understanding the pathology here, HCM is really characterized by abnormal myosin and actin cross-bridging mechanics. This leads to a significant amount of hypercontractility, and we see this in our echoes, right? We see individuals with hypertrophic cardiomyopathy have really hyperdynamic LV function, and this is primarily a result of this abnormal cross-bridging. And so the Seidman group in 2016 published what was one of the more, I think, impactful papers in HCM, and really looking at finding this small molecule inhibitor of myosin, what was at that time called MYK461. And the thought process was, if we can find something that reduces that hyperdynamic function, perhaps, that we can change the way the heart is functioning in hypertrophic cardiomyopathy, potentially lessen hypertrophy and LVOT obstruction. And what they found is, in small animal models at least, that yes, in fact, they were able to, with using the small molecule inhibitor, reduce fibrosis on the left here, but also really remarkably reduce wall thickness even in these mice. And so this really gave strong credence to the idea that potentially modulating this myosin, the ATPase activity of myosin, may in fact really improve symptoms in individuals, but this has to be tested. And so the development of mavacamten really targets this pathway of this hypercontractility. And in 2020, the first reports of this in a randomized controlled trial for individuals who were assigned to mavacamten, we see that not only was there improvements in wall stress indicated by reductions in their BNP over a course of 30 weeks, now, with data now extended out to more than a year, that these individuals did have a significant improvement in their LVOT obstruction. The caveat being there are some individuals who did develop a drop in their left ventricular ejection fraction. And so that is one of the reasons why the FDA, although they did approve this medication, there is a warning for individuals that this may be a side effect of the medication. And we're not going to get into too much specifics here in terms of how we utilize this medication. And if you are interested, Tuesday morning, we have a clinical conference led by our first-year fellow, Victoria, when we'll get into our specific experience with this medication. But for now, we'll basically just say, yes, it was FDA approved, and it is now part of our toolkit to treat individuals with hypertrophic cardiomyopathy. I do want to highlight, this use of this medication, but also just this clinic in general, really is a group effort. And with Rashad, I want to highlight one person who's had a significant impact in terms of our care for patients. That's Jason Matos in cardiovascular imaging. Jason knows I call him at all hours of the day to scrutinize LVOT gradients left and right. And so really want to thank him for his work in our clinic. Importantly, this can't be done without our echo lab, Jordy Strom, director of our echo, but also Jess Stout and Janelle McDonald, who have really taken initiatives in streamlining our echocardiograms and developing specific protocols to help really improve the quality of our echocardiograms. And finally, I can't appreciate enough the support we have both from nursing, but also pharmacy. This medication, mavacamten, is not easy one to prescribe, not easy one to monitor. And without these individuals, it really would not be possible. But I can't move on without actually just acknowledging the fact that we have an abundance of riches at Beth Israel Deaconess Medical Center. Not only do we have now new medications that we can treat our patients with, we have the premier surgeon for hypertrophic cardiomyopathy, really has one of the highest volume of septal myectomies really in the nation, and that's Dr. Rastegar. And Dr. Kavaz, who is our chief of cardiac surgery. I also want to highlight Dr. Laham, the director of our structural heart, who's done hundreds and hundreds of septal ablations. And together with anesthesia, cardiac surgery, the invasive septal reduction therapies is still a main part of our decision-making processes for individuals who don't respond initially to medications. So the question is, well, what's next? What else can we do in hypertrophic cardiomyopathy? What are we interested in specifically? We've spent a lot of time thinking about other tools that may improve our ability to understand hypertrophic cardiomyopathy, but also cardiovascular disease. And that takes us to use of multi-omics, including proteomics and metabolomics, transcriptomics, and high-dimensional data sets to really improve our prognostication for individuals with hypertrophic cardiomyopathy, but other cardiovascular diseases. And we're just beginning to really start the process of incorporating these omic disciplines into our HCM cohorts. And so this, in collaboration with Carolyn Ho from the Brigham, we're now studying the use of proteomics in hypertrophic cardiomyopathy individuals and understanding, well, what are the correlates for proteomics to developing atrial fibrillation, sudden cardiac death risk, but also, cardiac MRI findings as well. And so this work is preliminary, but something that we're very interested here in using high dimensional data to really understand HCM on a deeper level. But it doesn't just stop with just biomarkers of proteins and metabolites. This is work led by Reza Nafazet, who is part of our MRI group and has really been a pioneer in what's called radiomics. So using radiology imaging on a really high granular level, high dimensional level, and understanding how we can leverage imaging to improve prognostication in hypertrophic cardiomyopathy. So this is an analysis that he done very recently, and using LGE and performing radiomics analysis, PCA analysis, to really gain more information out of LGE and adding it to current risk models. And as you'll see, this has really improved, or at least in this series, has improved the prognostication of sudden cardiac death risk in individuals with hypertrophic cardiomyopathy above and beyond the current risk models that we use from ACC and AHA. And so both from an imaging perspective and also use of plasma biomarkers, we at Beth Israel have been really interested in how we can leverage omics to better understand our diseases, including hypertrophic cardiomyopathy. I want to finish up by just highlighting some of the key points that we talked about today. So sarcomere and non-sarcomere hypertrophic cardiomyopathy really are now distinct subgroups with differing implications for familial inheritance. We do have new sudden cardiac death risk markers for hypertrophic cardiomyopathy, including a drop in LVEF less than 50%, LV aneurysms, and late gadolinium enhancement. And novel myosin inhibitors really are targeting abnormal myocardial mechanics in hypertrophic cardiomyopathy and are now part of an expanded toolkit to help improve symptoms in hypertrophic cardiomyopathy. There will be now more applications now to individuals who don't have obstructive hypertrophic cardiomyopathy, have more just regular HCM without obstruction, but that data is to come. And finally, omics can really improve discovery and the clinical prognostication in hypertrophic cardiomyopathy. And so I really, I want to thank all of our contributors to this hypertrophic cardiomyopathy clinic. It really takes a village to take care of these patients, from electrophysiology to surgery and septal reduction therapy, genetics, cardiac imaging, research, and pharmacy support. It's really takes a lot of people. It's a very complex disease, but I think we have really the full complement of services here at Hypertrophic Cardiomyopathy in Beth Israel Deaconess to take care of these patients. And finally, I do want to specifically thank BI, our division, and really Rob and Peter for giving me the chance, really very close out of fellowship, to help lead this program. And it's meant a lot to get that support from the admin. That's all for today.
Wonderful. Thank you so much, Usman. That's a fantastic talk. We have a couple of questions in the chat. We'll start with one from Dr. Mike Meese. Are there any data on whether genotype positivity or other factors predict benefit or harm from mavacamten?
Yeah, it's a great question. It's something that I think is still ongoing in terms of our understanding. There was some hint in the initial data that perhaps individuals with genotypes, genotype positive, sarcomeric positive HCM may do a little bit better on the medication. But really, that is such a small amount of patients that have been studied. We can't really see anything specifically. But I do think this is going to be one of the main questions that are going to be looked at as more and more patients are on it. What is the response based on genotype?
Perfect. Thank you so much. I apologize for my background noise. What is the relation of age to symptoms and sudden cardiac death risk?
That's a great question. So, in hypertrophic cardiomyopathy, as you get older, there actually is less of a risk for you to develop sudden cardiac death. That the only caveat to that is individuals who do develop aneurysms Based on the case series, it seems like age really doesn't matter too much. But in general, the thought process is overall that the older individuals, especially after the age of 60, may have lesser a risk for development of sudden cardiac death.
Perfect. We have two hands up. We'll take a question from Jordy and then a question from Robert Gersten.
Thank you, Usman. That was an outstanding talk. I wanted to ask you about the prediction of benefit and harm from mavacamten. I think from an imaging standpoint, how challenging it is to get these patients on treatment. And while they're on treatment, they have multiple echoes, 6 or 7 echoes throughout the course of the year. And that really presents a barrier for a lot of sites that don't have the capacity to be able to take this on. In the Valor HCM study, there was only a small group of people who did drop their EF, and it was mostly sort of mild reductions in the EF. To Mike Mee's point, is there a way that we can either use omics or genotype data or even some clinical data to identify these individuals?
Yeah.
And really, for example, within the Valor HCM study, did they do blood banking? And is there a sort of a possibility to sort of leverage that to be able to really understand who these individuals are?
Yeah, and this is again in unpublished data, but there was a specific genotype in the trials that likely predisposed individuals to dropping their EF. That hasn't made it to clinical practice yet, but that is something that they're going to be looking at. And I think that is a focus for all groups studying hypertrophic cardiomyopathy, how can we identify individuals who may drop their EFs overall, because that is the main barrier. And you're right, it's incredibly cumbersome to do all these echoes. Our patients get 7 echoes in a year. And when you start off the conversation by saying, listen, this is going to be 7 echoes in 1 year, it turns a lot of people off. And so being able to identify who may actually have that drop in EF is incredibly important. And I do think there's roles here from genotyping, but also omics to really help identify novel biomarkers that may put individuals at risk.
Great. We'll take a question from Dr. Gersten.
Usman, that was a fantastic talk. One brief comment and then a question. So the brief comment is I realize you couldn't put everything in your slides, but I think it's really important to acknowledge Jim Sputich on whose work on molecular motors won him a Lasker Award at Stanford. I remember him speaking about this probably in 1998 or 1999 about the possibility of developing these kinds of drugs. So he's really the father of the field, and it really shows how basic science research can be converted to real clinical realities. The question is one that I've been asking for a long time. Have we been able to identify yet, because I keep on looking, I haven't seen any credible genetic variants that are balancing, i.e., that explain some of the variability in a lot of this autosomal dominant variable penetrance disease? Anything that might mitigate this?
Yeah, the short answer is no. That's the holy grail, is finding that balancing variance on a consistent kind of basis. But what I will say is that we know that even in individuals who have the genotype, that the genetic background, but measured by apologenic risk, may modulate individuals' risk for developing full-blown hypertrophic cardiomyopathy in the future. So we haven't consistently found something that is a direct antagonist or a balancing mechanism for these sarcomeric variants. But there is evidence that there is a genetic background that may modulate your risk, and the degree to which that happens is still in question. But I think there is hope there that we may be able to get more into this in the future.
So until then, we'll check family histories.
Family history is incredibly important.
All right, thank you. We have a question from Dr. Kaylin Ho. Can you comment on asymmetric septal hypertrophy in the elderly and how this fits within the HCM spectrum?
Yeah, and that's really muddy waters here, right? Because individuals who are older, we see these, septal knuckles and isolated basal septal hypertrophies, and some of them do end up having LVT obstructions. And so I think that we want to be careful in terms of not labeling everyone as having hypertrophic cardiomyopathy. But I think if you have if you have an elderly patient who has abnormal pap muscle architecture or has an LVOT obstruction or other signs of hypertrophic cardiomyopathy in addition to their isolated basal septal hypertrophy, I think that you do want to evaluate them for symptoms because we do have treatments now that can really help them. So I think, yes, it is muddy waters, especially in elderly patients, but we do have ways to really slice that population in more granular detail.
Usman, I'm going to ask one final question, which is about overlap syndromes with hypertrophic cardiomyopathy and other types of cardiomyopathy. We've shared some patients who've gotten anthracyclines or potentially peripartum cardiomyopathy. Is much known about that?
Yeah, so in terms of just other types of cardiomyopathies, yeah, we know that there are individuals who have shared genetic architectures. There are mutations that actually shared between dilated cardiomyopathy and hypertrophic cardiomyopathy, but they have different mechanisms of how they get to each. And so while there is shared genes across different cardiomyopathy subtypes, the mechanisms of how we get there do differ between hypertrophic cardiomyopathy and peripartum or dilated cardiomyopathy. So one gene may specifically, for instance, the filamin C gene may cause a restrictive cardiomyopathy, may cause a dilated cardiomyopathy, and the MYBPC3, MY7 both can cause dilated and hypertrophic cardiomyopathy. So there are overlap in terms of genes, but how they get there and what part of the gene is involved may be quite different.
Okay. Well, thank you very much. That was a really wonderful talk. We'll let everyone get to fellowship interviews. Thanks, everyone.